Hello, and welcome to Cottage Cardiology Clinic's virtual Meet the Doctor featuring Dr. Elizabeth Hutchins. I'm Christina Cortez, the Public Relations Manager for Cottage Health, and I'm so glad you could join us today. Before we begin, I'd like to share a couple of quick notes to help get the most out of today's webinar. At the end of the presentation, we will have a time for a quick question and answer session. So please submit your questions at any time using the Q&A button at the bottom of your screen. Also, today's webinar is being recorded, so we will send you a link afterwards so you can watch it again or share it with others. It's now my pleasure to introduce Dr. Elizabeth Hutchins. Born and raised in Santa Barbara, Dr. Hutchins is board certified by the American Board of Internal Medicine in Internal Medicine and Cardiology, and is also board certified in Adult Comprehensive Echocardiography. She earned her Doctor of Medicine degree from Columbia University's College of Physicians and Surgeons and a Master's of Science in Clinical and Molecular Nutrition from Columbia University's Institute of Human Nutrition. Dr. Hutchins completed her internal medicine residency at Harbor UCLA Medical Center and fellowship training in cardiovascular medicine at the University of California, Los Angeles, where she also served as chief fellow. She has a PhD in medical informatics from UCLA, which she completed as part of cardiovascular medicine training, and her clinical research interests include cardio-oncology, cardiac imaging, and the use of artificial intelligence and informatics to enhance cardiovascular care. Dr. Hutchins has authored peer-reviewed publications and presented research at national cardiology conferences. It's a pleasure to have her with us today, so please join me in welcoming her.
Hi, I'm Dr. Elizabeth Hutchins, and I'm going to talk today about understanding the role of a cardio-oncologist. Okay, so a little bit about me. Thank you for the kind introduction, but I'll just go briefly over a little bit of a recap of what you just said. I was born and raised in Santa Barbara. I went to Columbia for undergrad, followed by a master's in nutrition and then medical school. Came back to the West Coast for residency at Harbor UCLA, followed by cardiology fellowship at UCLA, where I focused on cardio-oncology as my clinical interest in fellowship. As part of my fellowship training, I also got a PhD in medical informatics at UCLA, and I focused a lot of my research on cardio-oncology research and specifically. I started at Cottage Cardiology Clinic this past September, and I see both general cardiology patients and also cardio-oncology patients in a growing practice. So today we're going to talk about three main things. The first is the prevalence of cancer, cancer survivorship, and cardiovascular disease. Then we'll talk about the role of the cardio-oncologist in keeping your heart healthy through cancer treatment. And finally, what you can do to keep your heart healthy during cancer treatment. So to start off, we'll talk about prevalence of cancer, cancer survivorship, and cardiovascular disease. So cancer is everywhere. In 2022, there were an estimated 20 million new cancer cases and 9.7 million cancer deaths worldwide. This is worldwide data. You can see that most common cancers are lung, female breast, colorectal, prostate, and most common mortality from cancer, lung, colorectal, liver, breast. Cancer rates have been sort of slowly increasing over time. So if you look back in 1975, you can see that there's sort of a general shift upwards in terms of cancer incidence. These three dots actually represent cancer diagnoses in 2020 during the COVID-19 pandemic. There was obviously underdiagnosing of cancer. So these sort of dots are outliers. But in general, you can see that the trend is going up in terms of new cancer diagnoses. A lot of this is driven by an increase in cancer cases in young people. So you can see here that the orange dot represents that there's been an increase in cancer cases in a particular age range. So for people ages 30 to 39, there's been an increase in cancer diagnoses and then relative decrease in cancer diagnoses in people over age 50 and stable for the other two groups. However, cancer death rates are actually decreasing. So you can see for the past 30 years, this is from the American Cancer Society, this slide. For the past 30 years, there's been a pretty significant decrease in the amount of people dying from cancer every year. This is a nice graph again from the American Cancer Society that shows if cancer death rates had continued along the same line that they were in the 90s, we would have this red line representing cancer deaths. However, this blue line represents actual cancer deaths, and this difference in between represents 3.2 million cancer deaths averted for males and 1.5 cancer deaths averted for females. This is another slide just showing more people are surviving cancer. So this graph basically stratifies people by time since diagnosis. And you can see that for all groups of people, time since diagnosis is going up, representing that there's much more cancer survivors living in the US, projected to be about 20.6 million, or sorry, 26 million cancer survivors by 2040. This represents just a breakdown of the cancer survivors by age. You can see that about 2/3 of them are 60 and over. So just to summarize that, there's been increased incidence in people diagnosed with cancer, plus dramatically improved cancer therapies, which has led to more cancer survivors and more people living with metastatic cancer. When we just break it down by site, we can see that for males, the most common cancer that people live with is prostate. For females, it's breast. And then for all sites, there's about 8 million men and 8 million women who have survived cancer. Those numbers are expected to increase to about 11 million for both men and women by January 1st, 2030. Cancer survivors have higher rates of cardiovascular disease. So, people with a history of chemotherapy and/or radiation are more prone to cardiovascular events. They have a 15-fold increased risk of heart failure, 10-fold higher rates of cardiovascular disease, 9-fold higher rates of stroke, and 7-fold higher mortality rate overall. And this is actually quite interesting and poignant, I think, for my talk, that the risk of cardiac death in patients who've been treated with chemo and or radiation is actually higher than the risk of the tumor recurring. So for cancer survivors, cardiac disease becomes very prevalent. Why are cancer survivors at a higher cardiovascular risk? Well, they share a lot of the same risk factors, but then also cancer therapies do play a role. So if we look at this, which I took from Jack Cardio-Onc, recently published paper, there's a lot of pathways that are basically similar for cardiovascular disease and cancer. This includes biological pathways, demographic and socioeconomic factors, lifestyle factors such as smoking and alcohol use, physical inactivity, diet. Pollution plays a role in both. And then comorbidities, which just means other medical diagnoses that contribute to both, such as diabetes and hypertension. But then also cancer therapy plays a role in the development of cardiovascular disease, and we'll talk a good amount about that today. So, how does a cardio-oncologist play into this, and how can they help people with cancer and comorbid cardiovascular disease? Well, a cardio-oncologist understands cancer treatments well and how they affect the heart. So today, what I want to do is talk about 4 common types of cancer therapies that are known to affect the heart, and then we can go through and talk about how a cardio-oncologist will help treat the cardiac complications of these therapies. But I want to emphasize that there are many cancer therapies that cardio-oncologists are aware of and that can potentially affect the heart. These are kind of the 4 of the most common ones. So we'll start with anthracyclines. The names for these are doxorubicin, daunorubicin, epirubicin. You'll notice they all end in rubicin. Doxorubicin is also called adriamycin. These treat breast cancer and blood cancer, and they're associated with a dose-dependent risk of cardiotoxicity. The cardiotoxicity they cause is heart failure. These are nice pictures of the medication. Sometimes it's called the red devil because it is red and it tends to make people feel not very well. The upside being it's very, very effective and can be life-saving for cancer. So I told you that there's a dose-dependent risk of heart failure. So what does that mean? It just means that as we give more doxorubicin, your risk of heart failure goes up. There's things that shift this curve to the left, meaning that for the same dose of doxorubicin, there'll be a less dose of risk of heart failure, and things that shift this curve to the right. So for the same dose of doxorubicin, there'll be more risk of heart failure. But in general, the relationship is that as you increase the dose of doxorubicin, your risk of heart failure increases. So, what oncologists do is they usually cap people around 450 milligrams per meter squared of anthracycline therapy, which has an associated 3.3% prevalence of CHF or heart failure. Once you get up to 600, we kind of consider this an unacceptable risk of heart failure at 8.7%. And then, of course, with lower doses, the risk is much smaller. So we know that anthracycline cardiotoxicity leads to overall worse survival. So this is a graph that looked at lymphoma patients that were treated with anthracyclines, and it's stratified by people who did develop the cardiotoxicity in the dotted line and people who didn't in the solid line. And you can see that for all-cause mortality, if you have the anthracycline cardiotoxicity, you have much higher rates of mortality, and that goes for lymphoma mortality and cardiovascular mortality as well. However, early detection from frequent individualized monitoring can lead to better outcomes. And basically, we can treat this cardiotoxicity if we catch it earlier and help sort of mitigate the risk of developing that. So how do we monitor patients? Well, this is a slide that basically shows patients are grouped into low risk, moderate risk, high risk, and then their monitoring protocols, which you certainly don't have to understand here, are designated by their risk. And my point here is to say that a cardio-oncologist can help determine individualized cardiovascular monitoring protocols for cancer patients. So we know these monitoring protocols very well, and we can work with your oncologist to develop a protocol that makes the most sense for your treatment. Okay, how do we monitor patients? Well, of course, we monitor with symptoms, vital signs. Those include blood pressure and heart rate, as well as respiratory vitals, EKGs, and then imaging. I want to talk quickly about imaging. So this is sort of the mainstay of cardiology in terms of what we get for imaging, and this is called an echocardiogram. What this is a ultrasound of your heart. So you lay on your left side, and we put an ultrasound probe in and get pretty picture of the heart. This is the main chamber of your heart called the left ventricle. It's just a muscle that squeezes the blood out of your heart and into the rest of your body. You can see that in this one, or you can take my word for it, that in this one, the heart is squeezing very vigorously, and it's a healthy heart. This is an example of someone with anthracycline cardiotoxicity. You can appreciate here that the heart muscle is just not quite squeezing as well as it is here. And this is sort of an example of what we're looking for when we're screening you with echocardiograms to determine whether or not you have any effects of the anthracycline on the heart. Sometimes the echocardiogram images are not as beautiful as they were there, and sometimes they're a little bit more challenging, or we need to be really precise in order to understand what we're looking at and whether or not the cardiotoxicity developed. And in those cases, we can do an echocardiogram with contrast. This is an example of the same study that I showed you before, the echocardiogram, but you can see here that we've given a contrast agent that lights up the left ventricular cavity and makes it really easy to see the function of the heart. But if that even isn't sensitive or specific enough, we'll order something called a cardiac MRI. And I have a clip here. You can appreciate, we can see very well the squeezing function of the left ventricle. And this is sort of the absolute gold standard if your echo images are not as helpful as we need them to be. Okay, so once we have this imaging, how do we know if you have cardiotoxicity? Well, the point of this is to say that there's many different guideline groups, and they all have different definitions of cardiotoxicity, which brings us to theme two. A cardio-oncologist can diagnose whether cardiotoxicity develops based basically on understanding all of these different guidelines, having had experience treating patients, and knowing what the cardiotoxicities tend to look like. Um, and basically, understanding these guidelines in detail and interpreting them in clinical context. And once it's found, how can we help treat it? Well, in the case of anthracyclines, in most cases, we will stop the anthracycline, so the offending chemotherapy, and then we can start medications. The medications we usually use are beta blockers, ACE inhibitors, or ARBs, and Jardiance. There are many trials that look at different combinations of these drugs and how they can be effective in treating anthracycline cardiotoxicity. And a cardio-oncologist will be familiar with these and can determine treatment protocols if the cardiotoxicity is found. Okay, so moving on to our second type of cancer therapy, we'll talk about HER2 therapies. So the names for these are Herceptin or trastuzumab, or Perjeta or pertuzumab. These treat breast cancer and gastric cancer, and they have a non-dose dependent cardiotoxicity, meaning any amount can trigger the cardiotoxicity. However, in this case, the cardiotoxicity is usually reversible. When you have HER2 therapy, every single person will get an echocardiogram at baseline and every 3 months while on therapy. But in contrast to anthracycline cardiotoxicity, HER2 cardiotoxicity is largely reversible. So HER2 related heart changes are often predictable, reversible, and treatable. And we actually may choose, in the case of HER2 cardiotoxicity, to allow them so you can finish your cancer therapy. This is a sort of guiding practice of cardio-oncology called permissive cardiotoxicity. And that brings us to theme four, which is that a cardio-oncologist can determine when permissive cardiotoxicity is advisable to allow continuation of cancer treatment. So just a little bit more on permissive cardiotoxicity. In this case, we're treating cancer through mild monitored heart changes. The old way of thinking was sort of protect the heart, stop the cancer therapy. But this newer way of thinking is that it's a speed bump and not a brick wall. We can support the heart through this and not need to stop the cancer therapies, with the goal of allowing you to get as much cancer therapy as possible to fight the cancer while supporting the heart through it. This is a spectrum of permissive cardiotoxicity, ranging from people who are at risk for cardiotoxicity, people who have cardiotoxicity but no symptoms, people with mild to moderate cardiotoxicity, and life-threatening cardiotoxicity. Right around here is where a cardio-oncologist will really have to make a decision whether or not we continue the cancer therapy and treat the heart through it, or recommend that the cancer therapy is stopped due to cardiotoxic side effects on the heart. This is a figure that I made for a journal article that I wrote, in which we go through all the different types of cardiotoxicities that can develop, the different drug classes that can trigger them, and then the strategies that we can use to help support the heart through continuing the cancer therapy. And this will be available in the slide deck that gets sent out if you want to read it in more detail. And just to sort of wrap up this idea of permissive cardiotoxicity, it's really just balancing competing risks. So of course, there's a risk of discontinuing cancer therapy. Of course, the cancer doesn't get adequately treated, but then there's a risk of continuing cancer therapy, and permissive cardiotoxicity is sort of this balance that we try to find between the two in order to give people the best health outcomes possible. Okay, the next therapies that we'll talk about are VEGF inhibitor therapies. So there are lots of these types of therapies, but some of the most common ones are sunitinib, also called Sutent, sorafenib, bevacizumab, which is also called Avastin. Um, these are mostly indicated for solid tumors, notably kidney cancer, thyroid cancer, colorectal cancer, and liver cancer. And the cardiotoxicity here, unlike anthracycline and HER2, which mostly cause heart failure or weakening of the heart muscle, this one causes increased blood pressure. So, blood pressure can increase 10 millimeters of mercury just within the first week in 20 to 47% of patients. So, when somebody gets prescribed a VEGF inhibitor, what we like to do, and this is an example that I share with permission of a patient that I saw at UCLA with Dr. Yang, who's sort of the person who mentored me in learning cardio oncology. This is a good example of somebody starting Sutent, which is one of the VEGF inhibitors that we talked about. And then just monitoring their blood pressure really carefully within that first week. So they started on the second, and by the fourth, they're getting high blood pressure readings. At that point, we increased their losartan that they were already taking. This sort of brought the blood pressure down, but then it went up and spiked again. We added chlorthalidone, and then we get these nice normal blood pressures. So normal blood pressure is around 120 over 80. And we see that when we monitor really close while you're on these VEGF inhibitor therapies, we can react and keep your blood pressure normal. And so that brings us to theme 5, which is that a cardio oncologist can work closely with you to treat any cardiotoxicities that develop. Okay, next we'll talk about radiation. This will be the last cancer therapy that we talk about. Radiation is a very important part of cancer therapy. But for certain cancers, the heart can be in the field of radiation. Most notably, the heart can be in the field of radiation for left-sided breast cancer, esophageal cancer, and then Hodgkin lymphoma that was treated before the 90s. And this can really cause a new type of cardiotoxicity we haven't talked about yet, which is coronary artery disease and then also valve issues. The coronary arteries and the valves can become sort of calcified and stenosed as a result of the radiation therapy. However, there's good news here, which is that modern radiation is much more precise than in the past. And there's new techniques that the radiation oncologist can do to target the radiation beam more directly at the cancer and sort of avoid getting the heart. One of the techniques is actually a deep breath hold where the patient holds their breath for 20 to 30 seconds, and that pulls the heart away from the radiation beam. So you can see here, patient took a deep breath, it shifted the heart out of the beam, and they're able to irradiate that left breast tissue without getting the heart in the field of view or in the field of radiation as it is here. And then also, a cardio oncologist will just know, if you've had radiation that's targeted the heart, and they can monitor you for development of the valve issues or coronary artery disease. And then, of course, healthy habits from the patient can greatly reduce risks of radiation effects on the heart. Okay, so to recap part 2 and the themes that we went over, theme 1 is that a cardio oncologist can help determine individualized monitoring protocols for cancer patients. A cardio oncologist can diagnose whether cardiotoxicity develops. A cardio oncologist can determine treatment protocols if a cardiotoxicity is found. We can determine when permissive cardiotoxicity is advisable to allow patients to continue cancer treatment. And we can work closely with you in the case of something like a VEGF inhibitor to treat cardiotoxicities that develop, sort of reacting in real time and making sure you get the appropriate therapies you need to support the heart and heart health. Okay, and so for our last section, we'll talk about what you can do to keep your heart healthy before, during, and after cancer treatment. So this is from the American Heart Association's website. This is Life's Essential 8, the 8 things you can do to keep your heart healthy. This is sort of in general, but then we'll go into a little bit more cancer-specific details in a second here. But healthy diet, especially the Mediterranean diet, physical activity, we'll go through this in detail. Blood sugar, just keeping your fasting blood blood glucose less than 100 or your hemoglobin A1C less than 5.7, maintaining a healthy weight, which they define as a BMI less than 25. Keeping your cholesterol under control. This is something we can help you with in cardiology clinic. Keeping your blood pressure less than 120 over 80. Of course, not smoking or vaping, and getting adequate sleep. So let's talk about physical activity and, in particular, how it relates to cancer patients. So, actually, the American Cancer Society has put out a statement on nutrition and physical activity guidelines for cancer survivors. And so I'm going to go through what they recommend in this statement. So, in general, they recommend to be physically active. That is defined as 150 to 300 minutes a week of moderate intensity physical activity, or 75 to 150 minutes a week of vigorous intensity physical activity, or some equivalent combination. They mentioned that achieving or exceeding the upper limit of 300 minutes is optimal. So, just to translate, this is 1 hour, 5 times a week. And then, in general, just limit sedentary behavior such as sitting, lying down, watching TV, just sort of staying active throughout the day. So, let's talk now about what constitutes moderate intensity and what constitutes vigorous intensity exercise. So, this is sort of straight from their guidelines. Moderate activities I describe as I can talk while I do them, but not sing. So, a very good example is just walking briskly. You'd be able to talk, but it would be a little bit uncomfortable. You'd be somewhat out of breath. Biking on level ground with a few hills, gardening, some more lower intensity sports, water aerobics. This is where you want to aim to 150 to 300 minutes a week. Or you'll do 75 to 150 minutes a week of vigorous activities, which includes jogging or running, jumping rope, hiking uphill, biking faster than 10 miles an hour, sports that include a lot of running, such as tennis, basketball, soccer, those types of things. Of course, during and immediately after cancer therapy, the full recommended hour a day, 5 days a week might not be feasible, but just keeping moving a little bit can help tremendously. And I like this that they put out this benefits of exercise that sort of go beyond the cardiovascular benefits of exercise during and after cancer treatment. It can boost mental health, reduce fatigue. It's kind of interesting, exercising makes you less tired, lose weight, decrease pain, increase mobility and strength, strengthen your immune system, and improve sleep. So, there was actually recently a trial that studied these general sort of guidelines very directly in the cancer population. And this is called the Challenge trial. So, it's a large randomized clinical trial. This is our best level of evidence when it's a randomized clinical trial that asks a simple question, which is, does exercise after chemotherapy improve outcomes? So participants were just people who got chemo for colon cancer, and they were done with their chemo for colon cancer, and they were randomized, meaning randomly assigned to either education about exercise or a structured exercise program. This was published in the New England Journal of Medicine in 2025, and it was really quite astounding, the results. So when they looked at people in the exercise group, people who basically were put in groups of people to exercise once a week, compared to just the people who got education about exercise, they could see quite a remarkable difference in disease-free survival, which means living without having a cancer relapse. You can see that the exercise group did much better in terms of not having a relapse of the colorectal cancer than the health education group. This difference was about 6.4 percentage points. So 6.4% of people did not have recurrence of their cancer in the exercise group as compared to the health education group. And then, even sort of more astoundingly, when we look at overall survival, the exercise group had a 7% percentage point. So 7% of of people died less between the groups, which if you think about a drug that we could prescribe that had, this much of an impact with basically no downside, that would be very successful drug. And really, it's just exercise, which is free with limited downsides. So this was sort of practice changing for people and really made us, a lot more wanting to recommend exercise to patients, particularly after chemotherapy. So, next, we'll touch briefly on adhering to a healthy diet. So, for this, I always recommend patients adhere to a Mediterranean diet, and that is what is in the cancer survivorship guidelines. So, Mediterranean diet is a whole food, plant based diet that includes lots of plant based foods such as fruits, vegetables, whole grains, nuts and seeds, and legumes, and also some lean protein sources such as chicken, fish, and legumes, and then limits red meat, particularly processed meat, processed foods in general, and sweets. And then lastly, I just want to mention symptoms. Don't tough it out. If you have any cardiac symptoms such as shortness of breath, chest pain, palpitations, dizziness, or passing out, please tell your treatment team. And you can ask if a referral for cardio oncology is warranted for your symptoms. But you can also come to cardio oncology if you have any questions about keeping your heart healthy through cancer treatment. So, in conclusion, today we talked about how cancer death rates have decreased and there are more cancer survivors living in the United States, and that cancer survivors have higher rates of cardiovascular disease and are actually more likely to die of cardiovascular disease than they are to have a recurrence of their cancer. We talked about how certain cancer treatments can put you at even higher risk of cardiovascular problems. These included anthracyclines, HER2 inhibitors, or sorry, HER2 targeted therapies, VEGF inhibitors, and radiation. And we talked about how a cardio oncologist can help diagnose and manage any problems with your heart that arise during or after cancer treatment. And then we touched on the importance of exercise, healthy diet, and monitoring your symptoms as important parts of staying heart healthy during and after chemotherapy treatment. And with that, I will wrap up. Thank you for your attention, and I welcome any questions at this point.
Thank you, Dr. Hutchins. That was a really informative presentation. So we'll now move into to answering some questions. So if you haven't done so already, please type your questions into the Q&A box, and I'll read them for Dr. Hutchins to answer. I will kick us off with our first question, which is, who should consider seeing a cardio oncologist? Is it only for people who already have heart problems, or is it helpful to see one before starting cancer treatment?
That's a very good question. So I think anybody who has cancer and is interested in keeping their heart healthy through cancer or has any questions about how their cancer therapy may impact their heart is a good candidate for cardio oncology clinic, particularly if you're on one of those agents or going to be on one of those agents that may have a high rate of affecting the heart. Um, and any cancer survivors that want to just discuss ways to keep their heart healthy after cancer, I think is a good candidate for cardio oncology clinic. And then certainly if you have cardiac symptoms while you're on cancer therapy, a cardio oncologist is a good resource to help discuss what we can do to help with that.
Perfect. Thank you for that.
Yeah.
Our next question is a referral required for patients to schedule an appointment with you?
No, you can just call the clinic and schedule an appointment. We take pretty much every insurance.
Okay, perfect. Our next question, are monoclonal antibody treatments associated with any risk to the heart, and should patients receiving these therapies be monitored differently?
That's a good question. So monoclonal antibody therapies, there's a lot of different ones. So I can't opine about all of them in general. I would have to know sort of specifically which one. Like, for example, one of the ones we talked about today, Avastin, is bevacizumab. That's a monoclonal antibody that can put you at risk of high blood pressure, as we talked about in the VEGF inhibitor section. But there's a lot of different monoclonal antibodies that that we would have to kind of get a little bit more specific about which one in order to answer what potential cardiotoxicities could develop from that.
Okay. And another cardiotoxicity question
Mhm.
is cardiotoxicity ever an issue with testosterone blockers such as I'm not gonna pronounce this correct.
Leuprolide or
Firma, firmagon?
oh, Femara.
Yeah.
Yeah, so testosterone blockers can increase your LDL, your bad cholesterol. And so a lot of times when someone's on androgen deprivation therapy, we just get a little bit more aggressive about monitoring and checking cholesterol levels in order to sort of mitigate any risks. Might check cholesterol a little bit more frequently. Or also get something called a calcium score to see if there's any calcium buildup in the heart as a result of the androgen deprivation therapy.
Perfect. Is it ever too late to see a cardio-oncologist? For
No.
example, if someone's finished with their cancer treatment, is it too late or
No, that's actually a great time to come, honestly, because once you're a cancer survivor, then you're kind of more at risk of heart problems than you even are of cancer recurrence. And so that's a great time to come and make sure everything that we can control in terms of your heart health is controlled, and we can order an echo and see you and counsel you on heart healthy habits going forward.
okay. Um, there is one okay, if developed let's say if developed severe calcification of heart
Mhm.
after radiation,
Mhm.
can the calcification be treated so the heart can return to normal?
That's a good question. So, you know, our main goal will be to prevent further calcification, but there is some evidence that's saying if you can get your LDL or your bad cholesterol down low enough with both statin medications and then also newer ones called PCSK9 inhibitors, that there can be actual plaque regression. That being said, we can also monitor you for very tight lesions that might need a stent. Sometimes stents can stents can open up and restore blood flow, and sometimes that's indicated in people with very high calcium.
One, I've seen a theme on a few questions here is let's say somebody is undergoing treatment for cancer currently, do you work closely with their oncologist or do you communicate with them?
Yes, yes. So I'm starting to get the oncologist cell phone numbers, and
Mhm.
they really like to get recommendations from me on safety of continuing treatment and monitoring protocols. And likewise, I get good information from them on how important certain cancer therapies are for treating the cancer, and we're working well together. And it's definitely a team approach.
Perfect. And then what about if someone already has a cardiologist, but they want to see you specifically for cardio oncology, same process?
Yes, yes, and I've actually had, several patients referred to me by, cardiologists, that just want a little bit more expertise in a cardio-oncology type issue.
Okay, perfect. Thank you for answering those. How does bone marrow transplant impact the heart?
So, bone marrow transplants, just can cause a lot of inflammation, which can affect the heart. You can get arrhythmias. You can get heart failure or weakening of the heart. It's not directly cardiotoxic, but there's just a lot of sort of ongoing inflammation that happens with it. We don't see super high rates of cardiac problems with bone marrow transplants, but certainly, if one develops, that's something we could monitor and treat.
Thank you. I think you covered this a little bit, but maybe we can repeat it for our guests. What are some of the symptoms of cardiotoxicity?
Yeah. So, symptoms of cardiotoxicity include shortness of breath. So, you might notice that, previously you were able to walk, on a flat surface without feeling any shortness of breath. But now you're getting a little bit more winded, or even feeling like excessively fatigued with walking or exertion might be like a symptom that your heart is under a little bit of strain. Um, there's also chest pain, of course, which can sort of present as chest tightness, chest pressure, squeezing of the chest, burning chest pain. Those can be symptoms that the heart is being affected by cancer treatment. Swelling is a big one. So, swelling in the legs, swelling in the abdomen. Along with that, you can get fluid buildup in your lungs, which makes laying flat difficult. Feeling short of breath laying flat or needing to use a lot of pillows at night can be a symptom that there's been cardiac problems. There's going to be a lot of them. I have a couple more. um, Also, waking up in the middle of the night, short of breath, can be a sign that there's been a cardiotoxicity. And then also palpitations. So, feeling your heart beat fast or irregularly in your chest. There are certain medications that can cause an arrhythmia or an abnormal rhythm of the heart. And That can be a sign that there's cardiotoxicity. And then also like excessive dizziness or passing out. Those
Okay.
are all reasons why you might want to be referred to cardio oncology.
Okay. Thank you for that. Let's say you're undergoing chemo treatment and you're not feeling any of these symptoms and you complete your chemo treatment and you're just feeling slightly fatigued. Is that a good time to see you, or is it cause for alarm?
I mean, slight fatigue can be common with cancer therapy or just overall deconditioning. But if you're worried about it or you have an intuition that, you're more fatigued than maybe you should be after cancer therapy, it could be your heart. I mean, there's probably also other things it could be, but it could mean that you've had a heart effect, and it could be a good reason to come and we can talk more. And I could take sort of a thorough history and really know your cancer therapies that you've received and sort of drill down your symptoms and see if that's a good time to do some of the heart tests that we talked about today.
Thank you for that. This one's specific to leukemia.
Okay.
What are your thoughts on exercising with immunotherapy drugs to continue your heart health?
So immunotherapy drugs, you definitely can still continue to exercise. We didn't touch too much on immunotherapy drugs, but immunotherapy drugs definitely can have effects on the heart. They're very, very rare though. That's why I didn't include it in the talk today. About like 0.5 to 1% of people on immunotherapy will get inflammation of the heart called myocarditis. Um, as long as you're feeling good, like exercise as we showed in that challenge trial is basically a drug. It's as it has, success rates of a drug that would be FDA approved. And so I would definitely continue it unless you're feeling anything very abnormal while you're exercising.
Yep. Thank you for that. Um, what are some of the early warning signs that cancer treatment might be affecting your heart?
Yeah, so sort of like we talked about, if you're just noticing like, previously when I walked up the stairs, I didn't feel so winded, but I'm feeling a little bit more winded. That can be an early sign. Feeling dizzy out of nowhere can be an early sign. Feeling more excessively fatigued, like your limbs are heavy, that can be a sign that there's something going on with the heart. Just sort of, the symptoms we discussed before, but even if you have them in a small amount, that can be a sign that there's cardiotoxicity developing.
Our next question, this is a good one. This is from the caregiver side of the topic. How can an oncology nurse or oncology nurses advocate for their patients? like if they suspect that there may be some heart health or that they should
Yeah.
seek help?
Yeah, that's a good question. I think an oncology nurse can definitely ask those pointed questions, like, do you feel short of breath, chest pain, palpitations, dizziness or passing out, any of those things to sort of cue the patient in to make sure they tell their oncology provider that they are experiencing these symptoms. They can also just sort of know which treatments are particularly cardiotoxic. So, kind of mostly the ones we went over today, and a couple others, and just sort of be aware, like, okay, these are cardiotoxic chemotherapy meds. These are the patients that I should really make sure, I ask these pointed questions too to make sure they're not developing the cardiotoxicity, and then encouraging early referral to cardio oncology, because the sooner we catch these things, the better we can treat them and the better outcomes we can have. So, certainly, like if a nurse is able to sort of cue in, ask these questions, maybe unearth some things that weren't going to necessarily come up in the visit with the provider or the MD provider, and then let patients know to schedule with me or ask for a referral to me or another cardio oncologist. That's a great way that a nurse can advocate.
Awesome. Thank you for that. Can you share a little bit about what a calcium score test is and is a
Sure.
blood test? How is it done?
Okay, sorry. So a calcium score is just a low dose CT scan. So just like you're getting a CT scan, you lay on that gurney and they put you through a scanner, but it's low overall radiation dose. And then they're able to actually count the amount of calcified plaque and come up with a score. So this lets us know how much calcified plaque is in the heart, to let us know if there's any basically atherosclerosis or plaque developing in your heart. From there, once we get the score, that'll be a number. You'll basically it'll be reported as a where you fall and like what percentile for your age and your gender. And then we have certain cutoffs basically to prescribe certain meds. So, like over 400, you might consider starting a baby aspirin. You know, it depends a little bit on your age, but elevated scores might encourage us to start statins or other lipid lowering medications. Even if the cholesterol doesn't look super bad, we might say, hey, okay, but the cholesterol doesn't look super bad, but we're developing some calcium. Should probably stop that process with the statin medication. So that's what a calcium score is.
Thank you.
Mhm.
Our next one is a little specific.
Okay.
Let's see. If someone is on CAR T for myeloma relapse, are they at greater chance of having cardiac damage?
Yeah, so CAR T is a little bit like bone marrow transplant, where there's just a lot of inflammation that can have. Basically, you can get something when you're on CAR T called cytokine release syndrome, which is just this release of all of these inflammatory markers, and that definitely can cause heart failure, really just due to sort of the stress on the body. It can cause like something we call like a stress cardiomyopathy. And it can also just all that inflammation can cause arrhythmias. So this will be in a small percentage of people, but there are percentage of people that do get cardiotoxicity from CAR T. And when I was at UCLA, we actually saw every CAR T patient before they got CAR T therapies, to, sort of advise on the risk of cardiotoxicity in that patient and any strategies that we could employ to sort of mitigate the risk.
Awesome. Thank you. Um, this one's a myth. I don't know if it's a myth or truth, so you can help us figure this out.
Okay.
This guest is asking us, they've read that flaxseed oil is harmful to men with prostate cancer. Is this true? And if so, is it a heart issue? Is it harmful to the heart?
You know, I'm not sure. There's no bad effects of flaxseed oil on the heart, is what I can say. I'm not sure if it affects the prostate in any way, but I think flaxseed oil is high in omega 3s. Omega 3s are very healthy fats, and they're good to incorporate in your diet. And so I generally tend to recommend things like flaxseed oil to my patients. So I think that's overall heart healthy, but I don't know if I could opine on if it's healthy for the prostate during cancer. I'm not sure,
Gotcha. Thank
but
you.
it's heart healthy.
Awesome. And then we have two questions actually where our guests are noting that they have their cholesterol levels are in the ideal range
Mhm.
or goal range. So they're wondering, does diet make any difference? If let me rephrase that.
Yeah, no, I think I understand the
You got it?
question.
Okay.
Basically, like, if your cholesterol is normal, do you still need to worry about your
Yes.
diet?
Yeah.
Yeah, I think the answer is, definitely. It's good to make sure that you're having a heart healthy diet. To ensure your cholesterol stays within the healthy range, and the other piece of heart health is overall sort of inflammation, and making sure you're not causing a lot of inflammation in the body, which can come from a less heart healthy diet. um, and then also, limiting things like processed foods and processed meats that have been actually shown to increase cancer risk. So, and then of course, maintaining a healthy weight is important for heart health and cancer risk. So,
Awesome. Thank you.
mhm,
If someone's had AFib most of their life,
mhm.
how does that play into chemo treatment once they receive a diagnosis?
Yeah, that's a good question. So, if you've had AFib most of your life, that's definitely not a reason to not get chemotherapy or appropriate cancer treatment. You should still be able to get your cancer treatment. There are some medications that are prone to causing uh, AFib, but in general, AFib is definitely something we can treat. We treat it all the time. There's a lot of different things we can do for atrial fibrillation, from medications to ablation to something called cardioversion, where we get you out of the rhythm. Um, and so that's definitely something that's very treatable, and we should be able to manage while you get your chemotherapy. Not a reason to not get chemotherapy.
Great, thank you. This is a good one. When sitting for, let's say, 1 to 2 hours and then standing up, sometimes will cause dizziness or lightheadedness. Could that be a sign of cardiotoxicity?
Um, that's very common. A lot of people
Mhm.
have that where they sit and they don't, and when they stand up, they feel lightheaded. Usually, the reason for that is that your blood vessels aren't kind of tightening up fast enough to get blood to your brain. But it's all context dependent. Like, if you didn't have that before and now you have it as a result of your chemotherapy, that might be something that we would look into a little bit further. Usually when people come to me with that, I'll order a ultrasound of the carotid arteries just to make sure there's no stenoses there, which would block the blood from getting to the brain. Um, so everything sort of depends on the patient and depends on the context. It could just be that the veins are not constricting when you stand up. It could be because you're having stenosis in the carotid arteries. Dehydration sometimes can cause that, not getting enough fluid or salt in your diet. It depends on the patient and the context, and in the context of cancer, what cancer therapies they received. But yeah, usually I'll scan the carotid. Sometimes I'll get an echo as well to sort of work that up.
Okay, thank you. Um, Next one, are oral HER2 treatments better on the heart over an IV infusion, or is that just dependent?
Not necessarily. No, any HER2 therapies can cause these effects.
Alrighty. And then do you see patients who haven't had the treatments you mentioned, but are cancer survivors?
Yes, definitely.
Okay.
Mhm. Yeah, there's so many different cancer therapies that can affect the heart, and I love seeing patients that have survived cancer and are now interested in optimizing their heart health going forward. That makes up a good chunk of the patients we see in cardio oncology.
So, and then there's another question. You already answered this, but about your working relationship with cardiologists and oncologists. But someone specifically called out they see one of the physicians within your practice.
Mhm.
So it would be the same thing, right? They could see you, but
Sure.
also you would work closely with
Yeah.
your provider.
Yeah, they're welcome to see me.
Okay. And then, is there any impact on the heart after many years of tamoxifen and other ER blockers after chemo, surgery, radiation?
Um, so tamoxifen, is like, kind of does the same things as androgen deprivation therapy. Um, it's not, it can basically affect your lipid profile a little bit, not as bad as the androgen deprivation therapy. The main issue with tamoxifen is, there's an increased risk of blood clots. But overall, it doesn't have that much effect on the heart.
Okay.
It's pretty safe for the heart, tamoxifen.
Okay. Thank you. We're getting close to the end. So there were a few questions that were um, very specific.
Mhm.
So we may not be able to cover those
Okay.
today. But one last question is for cancer survivors. How long did we ask this one already? Let me know if I already asked you this one. For cancer survivors, how long should heart health be monitored after um, cancer treatment?
So it depends on what kind of cancer treatment you got, and also, your symptoms. But you should always be, making sure that you're doing those things on the life's essential eight, keeping your cholesterol in a good range, keeping your glucose in a good range, keeping your uh, um, keeping your weight healthy, all of those things. And then if you have any, more specific questions, you can always come to cardio oncology to talk about any additional tests that would need to be ordered.
Okay, perfect. Well, that concludes our question and answers. A lot of great questions. Thank you all for your questions and for joining us this afternoon. Dr. Hutchins sees patients at Cottage Cardiology Clinic at 221 West Pueblo Street on the first floor in Santa Barbara. If you have additional questions or would like more information, you may call her office at 805-324-9707. Immediately following this presentation, you will receive a link where you can request more information or schedule an appointment with Dr. Hutchins. We'll also email you a recording of today's presentation in the coming days. A brief survey will also appear after this webinar closes, and we would really like your feedback. So thank you again for joining us, and we wish you a happy and healthy rest of your day.